Foundation for Ectodermal Dysplasias conference call to discuss the ectodermal dysplasias Big Three, skin, hair, and nails. So leading tonight's discussion, we have Dr. Alanna Bree. Dr. Bree is a dermatologist in private practice at Dermatology Specialists of Houston. Formerly, she was an associate professor of dermatology at pediatrics at Baylor College of Medicine. She graduated from Southern Illinois University School of Medicine in Springfield, Illinois, and she completed her residency training in dermatology at St. Louis University with fellowship training in pediatric dermatology at Northwestern University Children's Memorial Hospital in Chicago, Illinois. She has several publications and is co-author of a textbook on pediatric dermatology. Her special interests include pediatric dermatologic surgery and the ectodermal dysplasias. And we are thrilled to say that she's been with us on the NFED Scientific Advisory Council since 2006. So remember, tonight's discussion is being recorded, and it will be available on YouTube for future references. And Dr. Bree, I'm going to turn things over to you so that you can begin your presentation.
Great. Thank you. And thank you for the introduction. It sounds like there are a lot of familiar voices on the phone, which is great. And I've kind of set this up where I'll just kind of give some information over the top three topics that we're going to talk about tonight: skin, hair, and nails. As you guys know, I'm a dermatologist, so I'm best equipped to answer questions about skin, hair, and nails. So once we kind of go through a little bit of this information, certainly we'll have a good time for question and answers. But if you do have a question as I'm going through the material, please feel free to ask it at the time, and I'll try and give you the best answer that I can. All right, so starting with the ectodermal dysplasias, as you guys know, there are many, many different types of ectodermal dysplasias, but the thing that binds all of them in common are that all of the ectodermal dysplasias affect at least two ectodermal structures. And the ectoderm is the outer covering of the baby when it's being formed, and it leads to many things to be developed, but the most important with the ectodermal dysplasias are the sweat glands, the hair, and the nails. It can also affect many other glands and different organs as well and their interaction. So a lot of the complex ectodermal dysplasias have other things that are affected, but the things that join all of these in common are that they have at least two changes in either the sweat glands, the hair, or the nails. So as you guys know, the sweat glands function to regulate body temperature. That is why we have sweat to cool us down. In the ectodermal dysplasias, we know that the sweat glands are either abnormally formed or they do not function correctly. There are also some people with the ectodermal dysplasias that have completely absent sweat glands, so no sweat glands at all, which is more unusual to have absent sweat glands. Usually they're just decreased in number, abnormally formed, or they don't function correctly. And this is one of the main defining features of the ectodermal dysplasias. So having less sweat glands leads to decreased or absent sweating. The other name for this is also called hypohidrosis, or decreased sweating. We see the most significant decrease in sweat in those that are affected with hypohidrotic ectodermal dysplasia, the X-linked variety, but also the types that are inherited autosomal dominantly and recessively. But again, the classic is that X-linked dominant condition of hypohidrotic ectodermal dysplasia. There's also decreased sweating noticed in patients that have AEC, ankyloblepharon ectrodactyly and clefting, or EEC, less so affected in Golt syndrome. And you typically have normal sweating in the hydrotic ectodermal dysplasia, which is also known as Clouston syndrome. So how do we treat decreased sweating? So there's really no specific treatment to increase sweating in patients affected with ectodermal dysplasia. So really the most important thing is the need to focus on cooling techniques to prevent overheating. And certainly it's really important because those who are affected with ectodermal dysplasias overheating can lead to significant problems, including seizures and other things that are detrimental to the health. So basically, the signs of overheating that you're looking for, many of you guys know these, but just to go over them again, dizziness or lightheadedness, which can lead to fainting if severe, clamminess of the skin, feelings of chills, certainly extreme thirst or really dry mouth. Some people experience overheating with nausea or sickness to their stomach. Your heart can sometimes feel like it's racing, and you can sometimes have heavy breathing associated with being overheated. So what we want to do when we're overheated, hopefully we prevent that from happening with being prepared before going out to activities where that might be an issue. But cooling techniques that can be utilized to help when someone's overheated. I think the most important step is listening to your body, and I think it's really interesting that even before diagnosis, a lot of children with hypohidrotic ectodermal dysplasia, the children will lay on a cool tile floor or in areas where it's cooler on the floor, and they're already listening to their body. So I think that that is a great thing. And I think it's important to encourage adolescents and teenagers to continue to listen to their body because sometimes they forget about that. So the precautions that you should really take are when you know you're going to be going to an activity, make sure you load up and you have everything that you need for cooling. And also if you can tailor your activities, it would be great. And not that you have to limit your activities. I think people with ectodermal dysplasias can do whatever they desire with the right precautions, but maybe encourage your children to do swim team instead of track. But again, you can do anything with the right precautions, and if children choose to do sports where they're going, have a chance to overheat more so, I think you just need to make the coach and the teammates aware of the signs to look for in case your child forgets to listen to their body, which can sometimes happen. So basically, for cooling, you need to use external sources to cool yourself, since sweat cannot do it for you. So these are just a few tips, and I'm sure that if anybody has good tips to add in, I think learning from everybody's experience is the best way to learn. But certainly taking the water bottles that are available and freezing them in the freezer so that when you take them out, you can carry them with you and they'll thaw throughout the day if you're going to be outside for a longer period of time. You can take bandanas and washcloths, and you can put those in little baggies with some cool water. You can even freeze those and bring those along with you so that as those cool or warm up over the day, they're still cool in the baggie. And I think a good way to do it is carrying them in like a little soft cooler with the shoulder strap that they have out there for sodas and things. You can use those for the frozen water bottles and those chilled bandanas. There's a lot of things on the market now that have the cooling packs within them for the neck or the wrists, and I think those are nice, and they usually have a nice fabric on the outside that's soft. Portable fans, especially ones with the water misters, are really great, and you can usually find a lot of those at the beginning of summer and just kind of stock up on those for throughout the year. And then also cooling vests. Again, there's a lot of these available on the market. And they vary widely in how much they weigh, which I think is really important for a child. You want to look at the weight or talk to the company about how much it weighs, because if it's really heavy, they're not going to want to wear it. And then also the price can vary quite a bit. There is a list available of companies that have cooling vests through the NFED that you can get if you're interested in these. And from my personal experience and then talking to people, some people do like these, but I find that the kids, the children, they really don't like wearing them. They're limited by them. So, you might want to invest in a lower price one initially and see if they like it before you go on to, make a more significant investment in it. Right, so moving on to the skin issues. The skin issues that people with ectodermal dysplasias have are as varied as the different types of the ectodermal dysplasias that are out there. I think one of the most common issues that I'm asked about when I attend conferences is eczema. Eczema is very, very, very common. It's seen in 1 in 4 children in the United States. And it's even more common in children and people affected by ectodermal dysplasias, especially the hypohidrotic ectodermal dysplasia. Eczema is characterized by a red itchy rash that waxes and wanes, so there's periods where it's flared up and periods where it's better, sometimes without being able to figure out what exactly caused it to flare up. The most typical locations in a child under 2, you typically have eczema on the cheeks, the elbows, and the knees, and usually it spares the diaper area, so the diaper area tends not to be affected by rashes. When you're over 2 or into adulthood, eczema tends to involve the inside bends of the elbows and the knees, also the wrists and ankles. Sometimes it can affect the areas around the eyes as well. And when it's severe, it can virtually affect anywhere from head to toe of your skin. So some kids, when it's severe, it involves their scalp and basically all areas of their skin. And certainly eczema is known to run in families. If you have one family member affected by it, you have an increased chance, and certainly if you have 2, your chances go up of having eczema. So what eczema is, it's a very, again, common condition, so we're going to spend some more time talking about this topic. Eczema is also known as atopic dermatitis. So those words are interchangeable, and I tend to use eczema a little bit more frequently just because it's easier to say. We do know that children with eczema do have an increased risk of seasonal allergies and asthma, and we know that children with ectodermal dysplasias also have this increased association with seasonal allergies and asthma, which relates to their eczema. Eczema is not typically caused by a food allergy. It's actually rare for people with eczema to have a food allergy that's causing their eczema, and even if they do have an identified food allergy, avoiding that food does not typically help with the eczema. And that's not true in all cases, but it's true in the majority of cases. So I don't typically recommend food testing in children with eczema unless they have what seems to be a true trigger. So their eczema seems to get worse within a few minutes to hours after eating a certain type of food, and that happens on a consistent basis. But in patients with eczema, I always tell the parents it's really not important to be keeping a food diary of what you had 2 or 3, 4 days ago, because that reaction that leads to eczema is going to be almost immediate after eating that food. So what eczema is basically the underlying problem is that the skin barrier is not normal. And the reason we have skin is to keep good things in and bad things out. So the good things that your skin holds in is moisture. So the skin in people with eczema is essentially dehydrated because it has little micro cracks in the skin. It doesn't have all the components of a normal skin barrier. They're decreased in number so that water basically is able to leak out of the skin. And as far as keeping the bad things out, certainly people with eczema are more irritated by outside factors. They can also develop increased contact allergies where they become allergic to topically applied products. One of the most common things that people become allergic to is neomycin, which is in Neosporin over the counter, so I encourage people not to use that on a regular basis. And then also patients with eczema have increased risk of infections, including bacterial infections like staph. That's very common. They can get more ringworm, and then also viral rashes. So the virus that causes cold sores can also happen and spread in the places where children get eczema. And this is always going to look different than the regular eczema, but that's always something that when the eczema becomes worse or looks more red or starts to ooze, those are things that I think about causing that or secondary infections. Now, this abnormal skin barrier leads to increased inflammation, which causes that red rash that you see with eczema. And then that rash, that inflammation, leads to itchiness, which we call eczema the itch that rashes because that leads to worsening of the rash. And certainly when children are itchy, they're sleepless, they have sleepless nights, they're fussy, they have more trouble concentrating in school because they're tired. So that all kind of feeds into the process of what eczema is. And we also know that kids with eczema have a heightened awareness in response to minimal sensation. So they're always going to feel things more significantly than somebody that doesn't have eczema. And I think that's not only on the skin. They're going to, complain more about a bathtub or, the water in the bathtub or something burning or stinging their skin. But they seem to have a personality type, too, that they feel things more so. And that's just been in my experience. That's not reported anywhere. but the treatment of eczema. So, and again, this is also for dry skin. Eczema is kind of, dry skin to the nth degree. So all of these tips, not only if you have eczema, but even if you have dry skin, will be helpful. And dry skin is very common in ectodermal dysplasias. So
Dr. Bree, can I ask you a question?
Yeah, absolutely.
Is the molluscum that Zach had related to this eczema and the part of the ectodermal dysplasia, or
yeah, absolutely.
Just the molluscum related to the eczema then?
Yeah, so that's a great question. So molluscum is also very common. It is caused by a virus. It's in a virus that is in the chickenpox family of viruses, and molluscum, yes, is very, very common in children without eczema or without ectodermal dysplasia. I'd say in my pediatric dermatology clinic, I see it at least 2 or 3 times a day. So very, very common at baseline, if you will. I do see it more commonly in children with eczema, and part of the reason is the eczema, the skin barrier is not normal, so this virus is more easily able to invade and spread. So it is more common in kids with eczema. And then also some of the creams that we use to treat eczema, I kind of think of it as a fertilizer almost for the eczema. So topical steroids and also medicines like Topical or Elidel, those are the trade names that people tend to know them by. But those have been shown to make the molluscum worse in the areas of eczema. Mm-hmm. So I usually have people not put any active treatment in the areas of eczema that sometimes surround the molluscum, but just using barrier protection like a good moisturizer, even just plain petroleum jelly, is going to help repair the barrier, and then you're not using the topical steroids or the Topical or Elidel that can potentially make more molluscum in those areas. And when I talk to parents about this, when I'm seeing them in my clinic, I tend to just, liken it to a fever. If your child has a fever and they're uncomfortable, you're going to give them Tylenol or Motrin to help them feel better and bring down their fever. But if they have a small fever and they're not uncomfortable, most of the time parents don't give the Tylenol or the Motrin because they know that the fever is there for a reason. It's fighting an infection, and they don't typically give it. Same kind of thing with the eczema. A lot of times just having the molluscum in the areas of eczema, what that does is stimulates the body's immune system to make more inflammation. So a lot of times they get really bad eczema around their spots of molluscum. And so if they're terribly scratching at the area, they're also going to open their skin and have the chance of spreading the molluscum. So when they're, they have that increased risk of spreading the molluscum, then I say it's, best to use the medications if you need them. If you need to use the topical steroids a little bit, that's okay if they're miserable and they're going to be opening their skin barrier anyway by scratching. So it's kind of using your best judgment. If you need to use the treatments for eczema, do it if your child's significantly uncomfortable, but otherwise just kind of stick with using the Vaseline or other moisturizers in those areas. And then once the molluscum go away, the eczema tends to improve as well. But no, that's a good question. The molluscum, because it's a virus, is more common in children with eczema, but it's not necessarily related to the ectodermal dysplasias per se, but because more people with ectodermal dysplasias get eczema, there's kind of a backwards association. So that was a good question. All right, so moving on to addressing the skin barriers so we get less of those infections. I think the most important thing is good skin care. We know that people that have eczema, they actually have genetic changes in their DNA we're now finding where they are missing filaggrin. And what filaggrin is it's part of our skin barrier. There's a lot of pieces and components that make up our skin barrier. So now we know that eczema does have some genetic association with it. Not in everybody, but in a large majority of people. So because it's missing little pieces of the skin barrier, if you will, what we need to do is try and replace those from the outside. And we do that best by good skin care. So what does good skin care consist of? I think the issue of bathing is controversial. A lot of people say that not to bathe as often with eczema, but I actually think that bathing every day does a lot of good. You just have to do it the right way. So bathing every day, you don't want to do it too long or too hot. because that will disrupt the skin barrier. You also want to use a gentle soap or a soapless cleanser. There's many out there on the market. The ones that I tend to like are CeraVe cleanser, and then also the Cetaphil liquid cleanser that's available. I think those are nice because they kind of leave a film on the skin, and what that film does, it is a cleanser, so it's not leaving anything dirty behind, but it's actually leaving a film to kind of put an artificial barrier on the skin. And then the most important thing I think about bathing every day is that it decreases the risk of infections. It not only hydrates the skin, but it helps wash off some of those bacteria that are on our skin. Another thing that you can do if your child gets a lot of recurrent impetigo with their eczema or with their ectodermal dysplasia, you can add a little bit of dilute bleach to the bath water, and we call those swimming pool baths. And bleach actually is really a good antiseptic, and it's really not too irritating if you use it very dilutely. So you really don't want to do more than like about 1/4 of a cup if you're going to do a whole tub of water for a bath. And I do think getting in a bathtub at least a couple times a week if you have bad eczema is helpful. You can shower the rest of the days, but I think getting in the tub to actually soak and hydrate the skin is a good idea. So that, again, dilute bleach in the bath is good if you have recurrent infections and to decrease that risk. You do want to rinse with clear water after you kind of stand up from the bathtub just so you don't leave that behind and cause increased irritation because it can dry the skin a bit if not rinsed. And then another really important thing, this is where a lot of people go wrong with that daily bathing, is they don't apply a moisturizer right after they get out of the tub. So I always talk about the 3-minute rule. It's really, really important to get a moisturizer on the skin within 3 minutes of getting out of the tub. So you just want to pat dry and then put your moisturizer on right away. And what that does is help lock in moisture.
Can we go back a moment?
Yeah.
Going back to the bleach in the water.
Yeah.
Can you substitute vinegar?
You know, there are not any studies that I know about for vinegar, but vinegar does have antiseptic properties.
Right.
And we do recommend those if people get, like they have a surgery and they have a lot of increased excess healing. Sometimes we call that granulation tissue where it gets kind of real red and bleeds easily and it's almost like it's trying to heal too much. Dilute vinegar, which is acetic acid, does help with that. So there are some people that I know that do use that in their bath water, and they think that it's helpful. Okay. So, yeah, I don't know of any studies personally, but I have heard of that anecdotally, and again, we do use it sometimes after surgery if somebody's getting that increased granulation tissue or excess healing reaction.
Okay.
I've also heard people, oatmeal in the bath. The reason that sometimes feels good and why that helps is because the oatmeal, the little flakes of the oatmeal actually act like a little sponge and absorb a lot of water, and then those particles kind of disperse on your skin, and they act like little water reservoirs that release water to kind of hydrate the skin after you get out of the tub, and that's why that can sometimes be helpful as well. Skim milk. I've heard people use powdered skim milk in their tub, kind of probably for that same property, but there's no studies on that. But I have heard people that like that as well. The other thing, which I've sometimes talked to patients about, is green tea. It's an antioxidant, and we do know that green tea has been shown to help with inflammatory conditions or conditions that have inflammation, which eczema is one of those. And sometimes I've had patients where they boil a pot of green tea and put a little bit of that in the bath water.
Okay, I was going to ask, when you say green tea, do you mean pour it out of a bottle or green tea leaves?
Just like boil the green tea leaves. Sometimes, they come in those little tea bags, and people will boil that and then put a little bit of that in the bath water.
Okay.
Yeah, so that's something that you can definitely
do. Can you just put a tea bag in the
You
bath water?
can just put a tea bag in the bath water, too.
Okay.
Yeah, and all of these things, a lot of those things, again, are just people's experiences and kind of getting that out, kind of extrapolating that from the literature. But there's nothing that says that will help, but it's certainly a low-cost thing that you can try that won't hurt.
Right.
The one thing I do caution, I don't like, especially for children or babies, using a lot of bath oil in the water, just because it makes the tub really slippery, and I think that can be dangerous for falls. So I don't usually have people put oils in the water. Some people do like that, but I just caution it for, younger children or elderly people because I do think it increases the fall risk. So the best way actually to use an oil is to use it as a moisturizer after you get out of the tub. So, back to that 3-minute rule, applying that moisturizer right when you get out of the tub. Ointments and oils are always better, so plain Vaseline petroleum jelly is an ointment. Plain mineral oil is just a plain oil that you can put on your skin and use as a moisturizer. A lot of people don't like the feel of those, but they're the most consistent with what our skin is made of. Our skin is really made of oils, so you're kind of replacing oils with oils. They also don't have fragrances and other preservatives that can be irritating, and we know people with eczema get more irritation. So those are the best, and especially in those people that are very easily irritated. Now, creams are the next best thing. So a cream is, a good compromise. It has about equal components of water and oil, so it does have a high oil content, which is what we're really looking for. So a cream that comes out of a tub is really what you're looking for. There are a lot of creams out there over the market. You're going to run into different people with different preferences. I always encourage people to use it in a spot area. The ones that I have found to be less irritating for the people that I've taken care of, I think Vani Cream, V-A-N-I-C-R-E-A-M, is a great product line, and that's available at Walgreens. And also over the counter you can get CeraVe, and that's very good. That's a little bit easier to find. And again, they have a lotion and a cream, but I like the cream better.
Can you spell that, please?
And CeraVe is C-E-R-A-V-E. That's a good one. Cetaphil is another brand that has a cream. They do have nut oil in both the cream and the lotion, so I just caution you if you're sensitive to nuts or your child's sensitive to nuts, that sometimes that leads to flare-ups, the Cetaphil, if you're sensitive to nuts.
Does the Cetaphil, does that have antiseptic in it?
Not that I know of.
Okay.
They all have, some of the preservatives act a bit as an antiseptic, to prevent bacterial growth, but there's nothing per se that is an antiseptic in the product ingredient list that I know of offhand.
Okay, I was thinking that it did, but I don't know.
Yeah.
I got a question. I'm going to back you up a little bit, too. Be honest, I don't know what my daughter got. I don't know if she got eczema or what because we ain't seen a dermatologist in a while. But she have a syndrome, EEDC. And I remember one dermatologist told me if I don't put Vaseline grease or like Aquaphor grease on because it smothers the skin. But like all the others, some of you named out, but they do not work for her at all.
Yeah, I agree. I think, a cream is a compromise if your child won't, or if you're really averse to that stickiness or the oiliness of the ointments or oils. I think a cream is an okay alternative, but certainly I definitely, as you mentioned, the ointments and the oils are always going to work better. They're going to be less irritating. So sometimes doing an ointment or oil at night when you're not worried about being out and about in the daytime, and then doing a cream throughout the day, that's another compromise. But again, yeah, I agree with your comment. The ointments and oils definitely work better and are less irritating.
And I got one more question because I use bacon grease or Crisco grease at night, but her skin is it's light leather, but it's dusty, and she always wakes, like her whole body is like ash.
Ashy, yeah.
Ash.
Yep, and that's just from that really, really dry skin. So, yeah, again, you're addressing the skin barrier issue with applying that outside grease. So the greasier the better, and the blander the better. So the less on the product list, the better off you are because you're going to get less irritation. So yeah, greasing up as much as you can throughout the day, especially if the eczema is severe, is the most important thing, I think, in the treatment of eczema. And certainly now, moving on to the lotions are really actually detrimental to the skin. They actually have more water than they do oil, and when you put them on, they feel like they hydrate the skin a bit, but then what happens is that water evaporates off of the skin, and you actually get drying. So anything that's a lotion, I would not recommend for eczema, again, because it can dry the skin out. It also has a lot more irritants, preservatives, and fragrances that make it able to pump out of that bottle. So if you have something that pumps out of a bottle, I'd probably get rid of it if you're trying to make the eczema better. And again, less is more. In this condition, I say that a lot. With people with eczema, you really want to put less on the skin than more. A lot of people try to, use a lot of different things over the counter, and they're really just trying to help their child, but sometimes they're just exposing them to more things that irritate. So going back to plain old petroleum jelly is the best thing you can do. So read your labels, look what's in there, and try to get the label with the least amount of ingredients. Botanicals are not always good, so there's a lot of new cosmeceutical products out there that have botanicals or plant-based products out there. There are some that are good, but there are some that are quite irritating, especially in people with eczema. And I just always say that poison ivy is a botanical, and you wouldn't want to rub poison ivy on your skin. So that's always just something to remember and file in the back of your mind when you're looking at all those moisturizers over the counter on the shelves. And then also baby products tend to be uniformly bad for people with eczema. And the reason that is because that baby fresh scent comes from their lotions, and that baby fresh scent really is what irritates a lot of kids with eczema. So avoiding baby products altogether, even the ones that are made for children with eczema, I think are good because they tend to have a lot of fragrance. Another important tip with the moisturizers, because you're going to be getting them out of a jar or a tub, is you can contaminate the jar of the moisturizer. So again, we talked about the increased risk of infection on the skin. Staph bacteria is really common in people with eczema. And what happens is when you're moisturizing, a lot of people will dip their hand in that tub and then spread it around, and that's touched their skin where they have the staph bacteria, and then they put it back in the tub of moisturizer. And that staph basically can just grow in that tub of moisturizer then, and the next time you use it, you increase your risk of infection. So you really want to get out a small bit with like a throwaway plastic spoon or a popsicle stick, a craft stick that you use, and then, get it off of that craft stick or put it on a paper towel next to it, and don't keep dipping your hand back into that jar. All right, so moving on for prescription treatments for eczema, topical steroids really are the mainstay. They're the main treatment for eczema. There's all kinds of varying strengths of topical steroids. The percentage on it can be misleading, so the 1% over the counter is a lot weaker than, say, a medicine called Topical that is 0.025%. So again, don't look at that percentage if you get a prescription from your dermatologist. Topical steroids are arranged by class 1 through 7, and that percentage, again, can be misleading. Again, going back to the ointments, ointments are always better than a cream when you get a topical steroid. The same brand of topical steroid in an ointment is always going to do better and be less irritating than the same medicine in a cream version. Topical steroids, I think it's important to not consistently use them on the face, neck, groin, or underarms. Those sensitive skin areas are more prone to the side effects of steroids, so I tell most patients to avoid them on their face, and if ever they have to use them very sparingly for just a few days at a time. I also recommend that topical steroids overall, no matter where you're using them on your body, you try and use them less than 15 days per month. You don't want to be using the topical steroid like your moisturizer. The topical steroid's your medicine. You put that on first, and then you moisturize everything over the top of that. It's best if you apply the topical steroids to the areas of eczema right after a bath or when the skin is moist. You're going to get the best penetration and the best benefit from using that medicine. And then if you have a really severe flare-up, you can use a wet wrap. And there's all kinds of ways to do wet wraps, but what you do is you put that medicine on first, a good coating of the medicine, and then you apply the wet wrap afterwards. And you can take just like a dish towel that's damp or a washcloth, or you can use, like, I've had people use the little wristbands that they get at the sporting goods stores. You can use those, to slide up an arm on a small child because then they stay in place. You can take the tops of the socks, the elastic part, and cut off the bottom part of the sock, and you can use that, on legs or arms of children. So there's a bunch of different ways. Even when they're little babies, you can just use plain cotton PJs, like the ones that are long underwear PJs that have the long sleeves and long pants, and use that. And what you do is you, again, apply that thick amount of your medicine, and then you put the wet wrap over the area. So you dip it in water, you wring it out with a towel so that it's just damp, and you apply that first, and then you put another layer over the top that's not damp. So you can take another one of the wristbands or another, sock that you've cut out the bottom of, or another pair of just dry PJs if you're doing the PJs for a young child. And you put that dry pair over the top, and then that lets them run around. You can do it where you lay out towels on a bathroom floor, a wet towel and then a dry towel on top, but that kind of, especially for a child, they're not going to tolerate that as well as being able to run around with the wet wrap on. And then after about 20 minutes, you can take that off and then just moisturize over the top of that, and that will get you benefit. The longer you keep it on, the better. And some kids actually, and adults even, like to sleep in these overnight, the wet wraps, and that's fine too, as long as they're not getting chilled and they feel comfortable with it. Side effects of topical steroids, there are many potential side effects, but I think if you avoid those sensitive skin areas that we talked about and you really try to limit to less than 15 days per month, you're really not going to run into a problem with these medicines. But topical steroids can thin the skin, which then can lead to what looks like little stretch marks. It can increase little fine blood vessel growth in the area when it gets thinner. It can also discolor the skin where it looks lighter and shinier. So those are kind of the local side effects you can see with topical steroids. And then you can, in areas if you're using them around the eyes, that can increase the risk of glaucoma and cataracts. So that's why I really don't like to use steroids around the eyes. And if you're using them in a small child on a regular basis and not really taking a break and using them on a big body surface area, you can actually absorb that topical steroid as if you were taking a steroid pill by mouth. And that can then lead to delayed growth and all kinds of other bad things. Now, that's quite unusual to have it be that significant, but it does happen, so it's something to think about if you're using a lot of topical steroids. Now, there are other prescriptions that are available from dermatologists or other physicians. They're called calcineurin inhibitors, or the class, and these are anti-inflammatory medicines that do not have steroids in them. So the two trade names for the medicines that are out there and available are Protopic and Elidel. Protopic also goes by the word tacrolimus, and Elidel is pimecrolimus, but most people use the words Protopic and Elidel because there are not generics available of these medicines yet. And I do have to let you know that I have been a speaker for both of these companies, but I don't have any investments in them, but I do think they're good products and the only reason I speak for these companies is because I do think that they are good alternatives to topical steroids. And if used in the right way, I think they are helpful for people with eczema. And these medicines can be used twice a day. Because they do not have steroids in them, you don't have to take a break as you do with the steroids, so you can use them consistently every day of the month if you need to. They don't have the same side effects of the topical steroids. They don't cause thinning of the skin, lightening of the skin, and the absorption doesn't lead to those same problems that the steroids can. They can burn or sting a bit more than topical steroids do, and that's usually seen initially, and that gets better after a couple days. And I think the best way to use these, I use them as a steroid-sparing medicine. So usually I'll have a patient with eczema start with a topical steroid, and if they're finding that they're having to use topical steroids more than 15 days per month to keep their eczema under control, then I add this in to help limit the amount of days that they have to use the topical steroid. Also, if they're having to use a topical steroid on sensitive skinned areas where I don't like it to be used, like on the face or the neck or the private area, these are much better and safer options. And also, these medicines are not going to work as quickly as a topical steroid. They're not for flare-ups of the eczema. They're really going to burn or sting. These are really more for maintenance or during those days you're off of the steroid, which I call the steroid holiday. These medicines have been studied very closely and found to be safe in adults and children in many, many studies and many, many patients. Unfortunately, the FDA did put a boxed warning on these two medicines, and the reason is there were a handful of cases of skin cancer lymphoma reported in patients who had used these medications. They found that those bad side effects, those skin cancer lymphomas, were not felt to be caused by these medicines at all. It was just coincidental. but still, because of these handful of reports out of millions of patients that use these medicines, they did get a boxed warning. So that is something to keep in mind. I do caution my patients against that, but I do think it's a very, very safe medicine, and if used correctly, I don't think it's associated with those problems at all.
Dr. Bree, we have about 15 minutes left. I'm sorry to interrupt.
Okay. I'm sorry. I'm going on too long, aren't I?
That's fine.
Okay, so skin barrier products, Episerum, Mimix, Topical, these are considered devices. They've not been well studied for eczema because they're considered devices, not medications. So they're approved through a different pathway through the FDA. The studies that have been done by the companies have shown these to be beneficial. I kind of look at them as fancy moisturizers. They don't have many side effects, so I think they're safe, but they are expensive, and I think if you use a good moisturizer, you're going to get similar benefit. Anti-itch treatments are really important. The itch that's associated with eczema or dry skin, which is really common in ectodermal dysplasias, really is a learned behavior. It becomes a coping mechanism for these children. Because that's what they do when they're upset or they're tired. They always scratch, and that's kind of how they put themselves to bed, so it becomes like a security for them almost. It is the most difficult aspect of eczema to treat, I think. There are some products over the counter that can be helpful, but sometimes people complain about burning or stinging. Other people like these medicines, but menthol or pramoxine are two things that you can look for in active ingredients and anti-itch products over the counter. Another tip is to put the moisturizer or any of the prescription medications for the eczema in the refrigerator. And this is helpful because the nerves that sense itch are also the ones that sense hot and cold. So when you put something cool on the skin, it's going to calm down that itch sensation. That's why cool compresses or wet wraps are also helpful. Antihistamines are also an important anti-itch treatment. You really want to use the ones by mouth, not the topical creams. So the Benadryl cream can lead to significant irritation if used as a cream, so use it orally. They have shown that the antihistamines like Benadryl that are sedating are better for the itch of eczema than the non-sedating ones like Zyrtec or Claritin. And the reason that they work like that is because they allow the person to be a little bit sleepy, so that they don't scratch, because most people scratch most at night when they're in bed because they just don't have other things to kind of distract them. There really are limited side effects of the antihistamine, so I do encourage people that have itch to really use that to help break that itch-scratch cycle. And sometimes children and adults need psychological therapy to kind of break this learned behavior. So behavioral modification therapy is important. And I do see that sometimes the eczema, because it is such a significant condition, especially in association with an ectodermal dysplasia, which is a whole other issue on itself, can cause dynamics between the child and the parent to be not as optimal as they could be. So I think sometimes families even need counseling to kind of address that issue, and that helps break that itch-scratch cycle too. So now moving on with skin issues with ectodermal dysplasia. We covered eczema because it is so common, but skin issues with HED. A lot of babies with HED have peeling or kind of redness of their skin at birth. We sometimes call this a collodion membrane. The skin in patients with HED tends to be dry and thin and also light in color. Also, another common change that can happen and becomes more significant with time is the darkening and wrinkling around the eyes. And this can also occur around the nose, the mouth, and also on the neck a little bit. People with HED also tend to get what we call sebaceous hyperplasia, or those kind of little dilated yellow bumps that occur kind of on the cheeks and on the face. And those are what we think are dilated oil glands, but nobody knows quite for sure. Also decreased or absent fingerprints, and I know that there's been specials on this as well, but that is quite common. Skin issues in AEC. Again, these babies can be born with collodion membranes where their skin is really red and shiny at birth. The other thing that really affects people with AEC is skin erosions, or areas where their skin barrier is not normal and it's open. This is more common on the scalp, but it can also happen on the hands. And when it happens on the hands, some people refer to it as keratoderma because you have that open skin that then kind of gets thickened around it. And that's what we define as a keratoderma. So the scalp is the most significant area of involvement for these skin erosions. And because the skin is open, there's increased risk of infection. And in babies that have very severe erosions, they can get dehydrated, and that can be life-threatening. But that is fortunately very rare. Over time, they develop lightening or darkening of the skin. People with darker skin types tend to have lightening, and people with lighter skin types tend to have darkening of the skin. And people with AEC can also have decreased fingerprints. Skin issues in EEC and hydrotic ectodermal dysplasia, also known as Clouston, are not quite as common. Their skin tends to be more normal, if you will. In EEC, light skin is not uncommon, and then there can be areas of thickening over the joints. Clouston syndrome, they tend to get a thickening of the palms or soles, which we call hyperkeratosis or thickening. They can also have darkening of the skin over the knuckles, the elbows, the underarms, the nipples, and in the private area. So as far as treatment of the skin erosions in AEC, I think this is the most challenging skin problem. It's difficult to treat, and they tend to be recurrent, or they come back even after they heal up. I think the most important thing for treating these skin erosions is to treat them gently. Daily cleansing, again, with erosions, any type of erosions, is gentle cleansing. Ultrasonic misting, kind of like a water pick device, can sometimes be helpful. Dilute bleach is, again, good to decrease the risk of infection. I think it's then important to put on a bland emollient, so a moisturizer that doesn't have a lot in it. Again, going back to Vaseline, petroleum jelly is great. I think sometimes applying dressings can make this worse in some ways because it keeps it too moist, and then that increases the risk of infection. So I think a good compromise here is putting dressings on during the day because a lot of those areas are open, so keeping those covered is good when you're going to be out and about. It's really important to use a nonstick contact layer first. There are a lot of nonstick contact layers out there. There's Vaseline gauze. The ones that I like are made by a company called Monlycke. It's MOLNLYCKE, and they make a product called Mepitel, which is a nonstick contact layer. And the reason you want this nonstick contact layer first, after you put on that emollient, is because when you take that off, if it dries out, what it does is rip off the little baby skin cells that are trying to heal. So you really want to prevent trauma to aid in that healing so that those new skin cells that are forming have a chance to fill in and heal the erosion. And then just kind of keeping the dressings off at night just so it doesn't stay too moist, so keeping it open to air at night. I think keeping a high index of suspicion for infection, but I also caution people not to use antibiotics unless they have a proven infection, just because not only can they become irritating, they can become an irritant over time, but you can also get resistance for when you have a true infection. Then you have a microorganism that's resistant and is not going to respond to the antibiotic when you need it. I think the most important thing, too, is avoiding aggressive treatments like debridement, where they kind of try and get the dead skin off, and also grafting. We know people with AEC have problems with healing for many, many reasons, and it's due to the genetic changes in their skin. And a lot of people, it goes against what a lot of doctors are taught, that if you get that dead skin off, it's going to heal in. Well, because people with AEC have difficulty healing, that debridement and grafting actually sets them up for non-healing. So you have to be careful with those things.
Dr. Bree? I'm sorry to interrupt again, but we're almost out of time, so if it's all right with you, I'd like to open up for one or two questions.
Absolutely.
Okay. And if there's additional questions that we can't get to tonight, please feel free to email them to the NFED, and we'll get the answers for you, certainly.
I had a quick question. I was wondering if I could ask.
Certainly.
My daughter tends to, at times, get joint pain after she overheats. Is that because of the skin thickening around the joint, or is that something that could happen?
That is not something that I typically think of that's associated with overheating.
Okay.
I don't have a good answer for that question, actually, for you. I don't know if maybe is she being physically active at the time where she overheats, that she would be using her joints like in a sporting activity?
No, it's just if it's a warm day.
Yeah, I mean, That's hard for me to explain, to be honest with you.
Okay, and they're going to be checking for other autoimmune diseases, but
yeah, and
I understand that ectodermal dysplasia can open you up for other autoimmune diseases?
Yes, there has been some associations. So some people kind of consider eczema as an autoinflammatory disorder, which kind of falls into that autoimmune disorder. And seasonal allergies and asthma, food allergies, all of those are more common in people's ectodermal dysplasias. So there is some association, yes.
Okay, because she has a couple now, so we're checking for the others. Okay.
Okay, yeah, that's a good thing.
I have a question also.
Uh-huh.
I have myself and my 2 children, we all have these hooked nails, and they don't have they're hollow.
Okay.
And you can't really do anything with them, and my son got an infection in them, and the doctors really didn't know what to do. They kind of looked at you like you're aliens.
Right. So they're thicker or they're thinner?
They're thicker, and they're hollow in the middle. They're like a hoof.
Okay. So, I think we didn't get to kind of the treatments of the nail issues, but the nail also is your barrier to prevent infections. So I think the best thing that you can do is kind of use just Vaseline petroleum jelly around your nail bed as a barrier protection, and that'll kind of keep the area around it softer and healthier.
Okay.
So I think just using a barrier protection where you just take plain petroleum jelly and rub that in around your nail. There are also products out there that have small amounts of acid in them, salicylic acid or lactic acid, and those can soften the nails. So if you're having a lot of problems with kind of ingrown nails almost, you can use that and apply that on your nail plate, and that will help kind of thin the nail plate out a little bit so that it's not quite so thick and prone to that. So there is one over the counter called amlactin. It's not at a very high percentage, and it doesn't work really well for the nails, but there are a lot of prescription products that have salicylic acid or lactic acid at higher percentages, and that can sometimes help. But I think just that barrier protection, using the Vaseline on a regular basis, like at night before you go to bed, just kind of put a little bit of Vaseline, that'll decrease the risk of infection.
Okay.
I got a question.
I
believe they don't give my daughter the wrong syndrome. Because just listen to you, and you was talking about the ACE and the EEDC, and her skin falls up under the ACE, what you just were talking about, the opening, and when she was born, she had this big crust, like a big sore all over her head.
Yep.
And now her hands are like, you got a lot of sores on them.
Yeah, it does. Open. Yeah, it does sound like she has AEC. I don't know if you guys have been to a family conference, but I'd encourage you to come because there's always doctors at those family conferences, including me, and I'd be happy to, take a look at your daughter and we can talk about it a little bit more. Because, sometimes, and we didn't kind of get to that part, it's sometimes hard for doctors to know everything that they have to know. There's a lot out there to know, and not that it's a defendable thing, but I think, being your own best advocate, and, I know that there's people that are even on this conference call that help, lead to the right diagnosis with their doctors. So, looking at it as an opportunity, you definitely want to get a physician that you like and you can partner with, that you feel like they're going to help you, because, a doctor who wants to learn and is interested in your condition is going to be the best. But, finding somebody that you can work with and then talking about the differences, I think, is good. And there are handouts through the NFED. They're really good about educating not only families that have ectodermal dysplasias, but doctors and dentists around the country. So maybe getting one of the skin, hair, and nail booklets and bringing it into your physician and saying, maybe, do you think this might be something that she has, would be helpful.
I was wondering if I can ask you a question about, can you hear me?
Yes.
Okay. I was wondering, you didn't have a chance to cover the subject of hair at all. I have twins with ectodermal dysplasia, and one of the big challenges is we can barely brush their hair. It just seems to mass into these collections of tangled hair. And do you have any suggestions for that?
So for the tangled hair, that is, we call that the uncombable hair phenotype. So that is quite common in ectodermal dysplasias. using a little bit of oils or grease, that's really, you don't want to use too much because people with ectodermal dysplasia tend to have thin, light hair where you're going to see that and their hair is going to look a little greasier. But you can take like a little spritz bottle and put mostly water in there with just a little bit of mineral oil at a really small percentage so that it doesn't make it too oily, and kind of spray that on the hair right after, the bath. That'll help. And then, when it's dry during the day, using that a little bit. And that is probably the most helpful suggestion I have. But, yeah, there are microscopic changes of the hair when you look at it under the microscope that makes it difficult to actually comb through.
Is this something that they might outgrow, or is this something that's likely to stay for?
It's probably likely to stay. So people with ectodermal dysplasias tend to have thin, light, sparse hair that tends to be fine and brittle, slow-growing, with kind of patchy hair loss, or can be complete hair loss, and can sometimes be difficult to comb. So the hair tends to be kind of what it is. There are, different things that you can do to manage it, but I think, for that uncombable hair, just kind of a spritz with water and a little oil is probably going to be the best option. As far as,
thank you.
What if the child doesn't have any hair at all?
No hair at all. That's a little bit harder to deal with, I think, sometimes.
Yeah, I have a daughter that has that, and I have two children, one boy, one girl, and both of them were born with a head full of hair and eyebrows and everything, and they both lost everything.
Yeah. So in that condition, Rogaine's probably not going to help. I think if you have thinner hair, trying Rogaine over the counter is fine, even in children. Wigs are available. Peggy Knight is a good brand of wigs. It tends to be less irritating and that are actually really nice. They don't.
We tried that avenue with our daughter, and it got pulled off, so she's very traumatized. She wears caps right now.
Yeah, that's heartbreaking. Yeah, the National Alopecia Areata Society on their website does have some. They have different things for different head wraps and things that you can wear. Hair transplant, unfortunately, has a pretty high failure rate, and it's not an option for a child, and we really don't know what the outcomes are in ectodermal dysplasias. So really, that was, you kind of can't pick the skin that you live in, your skin color, and your skin type. So just, approaching it as positively as possible, which I'm sure you're doing.
Oh, yeah, she wears all kinds of hats, but she's not a girly girl, so we can't get girly girl hats.
Yeah, and luckily, hats are in style, and, that can just be her.
Wig, that's what you need.
Pardon me?
My daughter has the same problem with the wig, and the traumatizing is the exact same problem, but you need, have you ever heard of Locks of Love?
I checked with them, but she's not even interested.
Locks of Love wig, or any of the, Peggy Knight offers the same thing. You can pull it, you can go on a Ferris wheel, you can go on a roller coaster, and this thing will not come off for nothing. You really should give it a try.
I'm going to wait till she's a little older. She's 9 right now, and she's very traumatized.
My daughter was traumatized too. What'd you say?
What is the name of the wigs?
Well, Locks of Love is where my daughter got her first one, and you can jump out of a plane and it will not come off. And the kids will pull it and it will not come off.
And what was the other brand?
Peggy Knight. It's a suction wig.
Okay.
Yeah, and it's Peggy with a Knight.
Yeah, but just remember, lots of money.
Yeah.
Locks of Love, though, they'll help you, especially for a 9-year-old.
Yeah.
Oh, great.
This is Kelly with the NSCD. This is such a great conversation. This is always the hardest part of the night when I have to end our session. I'm so sorry because we are getting lots of good information from Dr. Bree and lots of great suggestions from all of you who've had these experiences. What I do want to encourage you, if you have questions that were not answered tonight, please send me an email to info@nsed.org, and I maintain our information account, and I'll see that we get answers to those questions, okay? But I do want to thank everyone for participating tonight, for your time, and Dr. Bree, thank you so much for the invaluable information. It's just just priceless. I can listen to you all night long and learn things. Well, thank you all very much, and watch your email for Dr. Bree's handouts and then information for the upcoming call in November, where you have a chance to chat with NFED founder and executive director Mary Kay Richter. All right?